My areas of interest really revolve around this concept of multimodality neuromonitoring, or trying to monitor the brain after injury. And particularly, we'll focus on traumatic brain injury for this session and how brain tissue oxygen monitoring sort of fits into this larger scheme and how it can be used to augment and individualize the care of your patients. I don't have any relevant disclosures for this particular talk. What we're going to go through is first recognizing the role of brain tissue oxygen monitoring within a multimodality neuromonitoring framework. We'll talk a little bit about the brain tissue oxygen dynamics that you'll see within the context of other physiologic data. And we'll talk about the existing evidence for the use of brain tissue oxygen as part of monitoring as part of multimodality neuromonitoring, and sort of a practical approach about how you might put this into clinical practice. So not everyone may be familiar with the multimodality neuromonitoring concept. And the question is, what exactly do we mean by that? But to answer that, we need to actually consider the whole point of neurocritical care. About 10 years ago, there was a consensus statement that set forth some language that I think beautifully captures our sort of raison d'etre, which is the fundamental goal in critical care management of these patients with neurocritical care disorders is identifying and preventing and treating secondary brain injuries that we know exacerbate outcome. But secondary brain injury is itself an umbrella term. It encompasses several different pathophysiologic entities. So what we know is that across the board, secondary brain injuries are common. Clinically, nearly a quarter of folks experience clinical neurodeterioration. And that's something that's important because it increases mortality by 150%, having the proportion of patients with good outcomes. So while things like brain tissue hypoxia or other mechanisms of secondary brain injury are common, the underlying physiology or their regulation is complex. So to simplify, I'd argue that the final common pathway of all of these, intracranial hypertension, hypoperfusion, hypoxia, is really an inability of the injured brain to match supply and demand through metabolic uncoupling. And this principle serves as the result of a primary injury, but also as a cause for secondary brain injuries. Hypoxic ischemic injury, of course, is sort of the final result that we are concerned about. This is the secondary brain injury that occurs, and it's clear from clinical and translational work that the majority of patients who experience fatal trauma have histologic evidence of ischemia. In a series of 161 survivors of severe traumatic brain injury undergoing xenon CT very early after injury, some 50 to 60% experienced ischemia. And over half of patients experience secondary ischemia over the course of the next 10 days. But histology shows that it's actually the capillaries, not the pedal arteries, not the larger arteries, that exhibit swelling of perovascular astrocytic infeed, luminal narrowing with decreased capillary filling, endothelial disruption, microthromboses. These large vessels are spared. So the ischemia that we see is not due to large vessel obstruction, right, or occlusion, but it's microvascular injury. Microthromboses, for example, have been described in what's called selective areas of neuronal necrosis. And that term, selective, is a hint that there's some spatial heterogeneity in these ischemic and hypoxic areas of secondary injury. And that's been highlighted by two very nice studies from the Cambridge group. And in one, they found that the ischemic injuries occurred in patchy regions, often distant from regions of structural injury after trauma. So in this image, the right frontal and temporal hemorrhagic contusions that you see show a decrease in cerebral blood flow, for instance, and cerebral oxygen metabolism. But within the contralateral hemisphere, which appears relatively structurally normal, cerebral blood flow is variably reduced, but the oxygen extraction fraction here is markedly increased, and that suggests or defines ischemia. And the ischemic volume of brain injury encompasses somewhere between 1.5% and 6% of the total brain volume. But an earlier study from the same group showed that that ischemic brain volume that we're talking about and the hypoxic brain injury occur independently in, again, these patchy, distinct regions throughout the brain, often distant from structural abnormalities. So physiologic derangements that result from this microvascular injury such as increased capillary transit time heterogeneity or diffusion hypoxia, mitochondrial dysfunction. These all serve to uncouple blood flow and substrate delivery from metabolism, and that creates tissue at risk. So back to our question, what is neuromonitoring? Well, the purpose is to access a set of measurements to help identify these secondary brain injuries that can cause tissue to go from at risk to frankly hypoxic or ischemic. And using measurements that reflect the mechanics, the pressure, the flow, the metabolism of oxygen or glucose, and the function of the tissue, ultimately, we can uncover more precise ideas of what that patient who's right there in front of us might actually need. And when we talk about brain tissue oxygen monitoring and its role in multimodality neuromonitoring, there's some consensus about the who and the why of why we're doing this. In our recent Delphi statement, the experts included in this Delphi process reached consensus that patients who are at the highest risk for secondary brain injuries benefit potentially from multimodality neuromonitoring, in part to guide individualized care. And so to do that, to be truly individualized and precise in our care, we're going to need to understand how brain tissue oxygen works. What does it tell us about this patient, and how should that change how we respond? So let's dive in. What is pbtO2 measuring? How does it relate to other measures of mechanics, metabolism, or function to inform our clinical decisions? So at its core, a brain tissue oxygen monitor is measuring the tension of oxygen itself within the tissue. That's the oxygen that freely dissolves out of a solution as that solution travels, in this case, across a capillary bed. And the brain tissue oxygen monitor that reflects this freely dissolved oxygen, that measurement has a nonlinear relationship with the oxygen within the blood coming into the capillary, or the paO2, arterial pressure of oxygen, and the O2 that remains within the blood as it exits, the venous partial pressure of oxygen. And that difference is the AVDO2, the arterial venous difference in oxygen, and the rate at which that blood is flowing through the capillary bed. Of course, oxygen is attached to hemoglobin, and that doesn't freely diffuse, but it's actually offloaded into the tissue. When the tissue gains enough supply of oxygen, some amount of that free oxygen remains unbound there in the interstitium, and that's what we're measuring. Now, I'll say when hungry tissue increases its oxygen extraction fraction, there's going to be less of that freely dissolved oxygen available, if that makes sense. But recall the oxygen delivery equation. So O2 is bound to hemoglobin, and that is the major source of cellular energy substrate. That's what the brain cares about. Free oxygen contributes less than 1% of the usable oxygen cells require, and that's really, really important. So while brain tissue oxygen, or pbtO2, as I'll call it, reflects flow and interstitial paO2, or dissolved oxygen, the delivery of oxygen to cells is predicated on saturated hemoglobin. So for instance, take this example. If the paO2 for a given patient is 80 millimeters of mercury, or 10.7 kilopascal, you might expect preserved brain tissue oxygen based on where this line is showing the paO2 relative to this modeling of brain tissue oxygen. But if you have a traumatic brain injury patient, the hemoglobin might be low. It might be 8, and it's only saturated 94% because you've got your vent at an FiO2 of 21%, preserving their saturation according to normal guidance in the ICU, right? But that would predict a pbtO2 that's actually less than 20 millimeters of mercury, which tends to be a sort of cutoff below which you consider the brain to have relative hypoxia. So if the majority of the available oxygen at the tissue level is recovered from oxygenated hemoglobin as it flows through the tissues, the question is, how do you optimally manage those patients so that the tissue oxygen we can measure is adequate? And there's a few options, of course, based on this, right? One, you increase the available hemoglobin that you can saturate. And two, is you improve the perfusion and flow through the capillaries. But if you just increase the paO2, or dissolved oxygen, it adds very little to what the neurons see. And in fact, it can actually cause harm. Now, the oxygen dissociation curve is an old concept developed over 100 years ago by Christian Bohr. And in the general ICU setting, it's increasingly clear that that freely diffused oxygen that comprises less than 1% of the overall content of arterial oxygen usable by tissue can cause harm, right? So in a prospective in-hospital cohort of 146 patients, with 220 ABG measurements. One study found they could recreate the oxygen dissociation curve. Now, granted, you're focused on a very small area where we tend to keep patients at saturations between 90 and 100% or so. But what they found was when your pAO2 became low, when you develop peripheral hypoxia, it was most common when the saturation, or SpO2, your plethysmography, was less than 94%. And hyperoxia tended to occur more commonly with a pleth of above 96%. So you sort of have an optimum saturation of hemoglobin that you can target in the ICU. There was a pragmatic cluster randomized crossover trial that was conducted in ICUs and emergency departments with some 2,500 patients. And interestingly, they showed even if you use a saturation target that is even lower, 88 to 92%, there seemed to be a lack of harm with patients in this Kaplan-Meier plot not having any difference in mortality or mechanical ventilation days. But if we mitigate the risk of dissolved oxygen by flirting with the lower end of this oxygen dissociation plateau, does that satisfy the brain's enormous metabolic demand, right? Particularly after a brain injury where we know metabolism becomes uncoupled from its substrate delivery. And the answer is very likely no. So we took a look at in preliminary data at 177 of our severe TBI patients, and that included 110,000 pbtO2 measurements and some 50,000 ABGs over these patients over time. And we were able to recreate the oxygen dissociation curve. In red here are the folks who had a P2F ratio of more than 300%, so fairly normal lung function. You can see there's a lot of overlap between those who had a P2F ratio that was normal and those in which it was low, but in general, you get a very similar curve. Now, if you add brain tissue oxygen to this graph, as you can see in the 3D graph here, the majority of the adequate pbtO2, as seen above this red line here, tends to occur at a relatively high SpO2, or oxygen saturation, but a relatively low pAO2, something around 150 or less. And we found a convincing increase in the values of pbtO2 that were normal or above 20 millimeters of mercury when the SpO2 values particularly were above 96% and even 98% relative to these lower strata. So if you maintain an oxygen saturation on your bedside plethysmography of above 96 to 98%, then you really optimize the chance that your brain tissue oxygen is going to be normal, where you want it. What we tell our folks and what we do in our clinical practice is maintain the SpO2 above 98% at the lowest effective pAO2. But what accounts for this curious phenomenon? That when the pAO2 and the SpO2 are actually both low, pbtO2 suffers, but in some cases, even the pAO2 being high and the SpO2 being 100%, there's still brain tissue hypoxia in a subset of these patients right here in this region of the graph. In order to get the hemoglobin-bound oxygen to the brain, another critical part, as I mentioned, is cerebral blood flow or perfusion. Now, after TBI, I mentioned microvascular injuries to mean that absolute flow is only part of the problem. Fewer than 10% of the areas with relative ischemia, as I showed on this graph earlier based on PET scans within the Cambridge group studies, overlap with the areas that develop or show hypoxia. In other words, low flow doesn't mean necessarily low oxygen. And there's two distinct problems despite these overlapping physiologic underpinnings. Hypoxia results in part from a capillary that doesn't fill evenly. And the pbtO2 catheter is taking in the average across many, many, many capillary beds. So when you have a situation in which flow is stagnant because the arteriole leading into the capillary bed is narrowed, for instance, right, then you extract as much oxygen as you can in the setting of low flow. And the interstitial partial pressure of oxygen tends to be lower. And on the other hand, areas in which there's high flow or shunting decreases the effective oxygen extraction fraction because there's no time to do so. and the average interstitial oxygen actually will be increased. But an average, as this area of low oxygen becomes diffused with areas of higher oxygen content in the interstitial space, the pbtO2 on average may end up being lower in this setting. So if we take this example, we try to crank up our PaO2, our delivered oxygen, artificially, what would happen to tissues that have this shunt physiology? You would increase the interstitial oxygen, and it would diffuse across on average, increasing your pbtO2. But as it changed, the fact that this tissue has decreased oxygen extraction and this increased oxygen extraction at the expense of lower blood flow. Other regulatory mechanisms are also affected by this microvascular pathology, such as autoregulation, right? Which is another further cause of mismatch between flow and oxygen delivery. There's a concept of tissue oxygen response. If you monitor brain tissue oxygen, you can use this relationship between the pbtO2 and the arterial oxygen in sort of an artificial way to test a couple of things. So one is you can test whether the probe itself is accurately measuring oxygen. So the oxygen has to diffuse into the probe. And if there's something that's blocking that, or a problem in which the oxygen is not being seen by the probe, when you crank up the FiO2 on your ventilator, for instance, your PaO2 should increase by a factor of 2 to 6. And the pbtO2, what you're measuring in the interstitial space, should go up, just like you see here in this pbtO2 tracing over a 4-hour reporting. Now, the tissue oxygen response can be quantified. In other words, a pbtO2 that also rises dramatically might suggest that you're not regulating blood flow. You're pumping that stuff in very quickly from the arterial system into the interstitial space. On the other hand, you might have a fairly normal tissue oxygen response, an increase of, say, 10 to 30 millimeters of mercury. And when the vessels have tone and it's a normal response to having increased PaO2, you might see the blood flow here in purple decrease, a normal vasoconstrictive response, not as strong as with CO2, but present with 100% FiO2, for instance. And in some cases, this tissue oxygen response is blunted. And the pbtO2 catheter, it sees the change in dissolved oxygen, but not as profoundly as it might normally. And that occurs in situations in which you have misery perfusion, ischemia, low cerebral blood flow, or extrinsic restriction of diffusion, such as the cerebral edema situation, right? You may have traumatic microvascular injury causing that diffusion hypoxia we talked about. And these all make this tissue oxygen response very sluggish. What's interesting is the oxygen response, when it's the most brisk, actually correlates linearly with this autoregulation that we talked about. So in this case, the pressure reactivity index, which is a number that represents, in some respects, the capacity of the brain to maintain blood flow over a steady mean arterial pressure, is actually in part reflected by the response of the brain tissue oxygen to an increase in the arterial partial pressure of oxygen. As I mentioned, a low tissue oxygen response, you can quantify this, right? A couple of different ways. There's two different methods that you might consider. One's the oxygen response based on changes in pbtO2 to changes in PaO2. The other is more of a percent change in pbtO2 called the CTOR. Either way you measure this, there have been a couple of studies, one in which CTP or perfusion computed tomography was used to show a fairly linear relationship between the response of the brain tissue oxygen to an increase in FiO2 based on cerebral blood flow. So the lower the flow, the more sluggish that response is, or the more muted it is. And that had an 81% sensitivity for detecting hypoperfusion of the brain after injury. In this older study, which is really nicely done using xenon CT, they showed that when your cerebral blood flow is lower, the oxygen reactivity similarly becomes much lower. I'll show you an example of this. This is 2 days of multimodality monitoring recording. You can see in the labels the different sorts of modalities that we're talking about, things like intracranial pressure, cerebral perfusion pressure, brain tissue oxygen, of course, blood flow, intertidal CO2, oxygen saturation, and this number PRX or pressure reactivity index. So what I want to show you in this example in the red lines are where we've increased the FiO2, and you can see the oxygen saturation here in the SpO2 tracing increases appropriately. So you ramp up your FiO2 in the ventilator, you should see an increase in the SpO2. You should also see an increase in brain tissue oxygen. But notice at the very beginning of this, there's no real change. There's no response to FiO2 challenge, in this case we might call it. But as soon as our CPP, which is fairly low here, begins to climb, we start to see that the pbtO2 similarly begins to climb. And at the same time, our intracranial pressure improves and our PRX declines, meaning we sort of reached a plateau, or we were at the lower limits of our autoregulatory ability when our CPP was lower. Now, notice the blood flow itself is quite low. It's oligemic. And that is why, in part, our FiO2 challenges initially weren't working at all and then became sluggish, muted over time in this setting. Right? So there's a relationship wherein the cerebral perfusion pressure and the brain tissue oxygen are relatively correlated. That's related to autoregulation. CBF shouldn't change throughout a range of arterial pressures, and that means pbtO2 shouldn't either. They shouldn't be correlated. But after an injury, if pbtO2 depends on this higher cerebral perfusion pressure, it suggests that there's a certain pressure under which there's compromise of flow, and pbtO2 thus becomes lower, less responsive to the PaO2 that comes into the tissue based on the blood flow through the capillary bed. Now you can quantify this correlation. You can mathematically correlate the brain tissue oxygen and the cerebral perfusion pressure. And sometimes that's termed the oxygen reactivity index, analogous in some respects to the pressure reactivity index. So if your brain tissue oxygen is correlating with or going along with cerebral perfusion pressure, that indicates that you're not auto-regulating as well as you should. When they're independent, normal regulation of blood flow is present. When the pressure falls below a certain point, flow and thus brain tissue oxygen necessarily decrease. If you plot the cerebral perfusion pressure here on the x-axis and how much that, or I should say those signals are correlating, the ORX on the y-axis, you can see here that as the CPP falls below 60 millimeters of mercury, our two signals, oxygen and CPP, become much more correlated. In other words, in this case, our optimum CPP should be somewhere above 60 millimeters of mercury to assure us that our perfusion through the capillary beds is adequate, or at least optimized, so that any other changes in pbtO2 now can be addressed thinking through oxygen delivery by hemoglobin saturation or some of the other mechanisms of hypoxia that we'll talk about next. So we can turn our attention to other problems by recognizing our CPP is okay. And just like we saw before, we can optimize our SpO2 and know that we've optimized that as well, allowing us to move on with essentially our differential diagnosis, right, based on this. Now, there was a study of 425 patients, and they calculated this ORX over the entire cohort. And the average value is similar, a little higher than the PRX perhaps, but it was associated with intracranial pressure, CPP, and even clinical outcome. And I'm overlaying that now on our own plot, and you can see they're similar, but what they found was that ORX number really identifies this bend, right, which represents the lower limits of autoregulation. And we just saw that just looking at the trends. You don't necessarily have to do a true correlation coefficient, but you can see these changes or these correlations over time. So as I mentioned, in some situations, the brain tissue oxygen is harder to treat. It takes a lot of PaO2 or positive indexatory pressure to saturate your hemoglobin. And even when you do, your brain tissue oxygen may not be adequate. At some point, it might become less about perfusing the brain, but rather about oxygenating the blood at the interface of the alveoli. The brain and the lungs are intimately linked in their physiology, and it's multimodality neuromonitoring that helps to understand which of the tissues has the problem that we need to address. And I'll show you an example of what I mean in a dynamic way. So in this example, individualizing brain oxygenation and lung ventilation both become critical to managing intracranial pressure blood flow and brain tissue oxygen delivery. This is a young man with traumatic brain injury and a left subdural hematoma that was subsequently evacuated. We've placed intracranial monitoring devices on the right side. What I'm showing you here, this is 12 hours of this patient's record, and it's the second day after trauma. And what you might notice is that our ICP here is adequately controlled, but our brain tissue oxygen is quite low at 10 millimeters of mercury. Our cerebral perfusion pressure, here in blue, is averaging about 65, and our cerebral blood flow, although it's sort of blunted, it looks like it's a fairly normal value. So we've got adequate perfusion in that sense. Our oxygen saturation here in orange, that's 100%. And our arterial blood gas at that point shows a pAO2 of 152 millimeters of mercury. So our P to F ratio is 380, which is considered good or normal. Now, the red areas that I'm showing you here highlight a clear relationship or correlation between the CPP and the brain tissue oxygen and the cerebral blood flow. And what this suggests is that when our brain tissue oxygen is low, this happens to reflect a problem with perfusion. We have a CPP-dependent brain tissue hypoxia. We need the extra perfusion, the extra pressure, and the extra flow to overcome the microvascular injury that's leading to that hypoxia. Right? So when you saturate your hemoglobin 100%, then you have to focus on whether it's a perfusion problem, right? And in this case, the brain tissue hypoxia resolves as our CPP improves with, in this case, the administration of vasopressors. Now, the next day, I want you to notice something. Here, our oxygen saturation begins to decline, right? It declines consistently and tends to worsen over time, despite a cerebral perfusion pressure that's averaging now 75 millimeters of mercury. And our pbtO2 here declines below the dashed line, which is 20 millimeters of mercury. Our end-tidal CO2 kind of increases over time as well. And there's a relative increase in the average intracranial pressure too. Now, some 6 hours after this drop in SpO2, you can see that our temperature increases. So we develop fever. And with fever comes increased CMRO2 or brain metabolism, comes vasodilatation. And you can see our autoregulatory capacity becomes dysfunctional as well based on this increasing pressure reactivity index. There's a massive rise in intracranial pressure in this context. We have vasodilatation, increased blood volume, and increased end-tidal CO2, compounding that. Our cerebral blood flow becomes hyperemic, and the SpO2 is even lower. We desaturate, and our pAO2 in arterial blood gas is just 74. Despite the fact that we've increased our FiO2 to 70%, we've increased our PEEP to 10 centimeters of water, and our P to F ratio is almost 100 at this point. Now you can imagine on X-ray, we have bilateral patchy opacification suggestive of diffuse interstitial lung disease at this point, whether edema or infection. And that's creating this problem at the interface of the alveoli. Now, in this case, pneumonia was our highest concern. Antibiotics were started. The fever was aggressively controlled. And we gave hyperosmotic therapy here in the red vertical line. And you can see the ICP responded nicely to that. The ventilator rate was increased for higher minute ventilation here at the black line. And you can see our end-tidal CO2 drops, which you would expect, right? And that pushes our ICP even further down to 5 millimeters of mercury. Thankfully, our blood flow wasn't affected by this relative vasoconstriction, which is good. You can see that's still in range. And we got some vessel tone back with that vasoconstriction, which allowed us to autoregulate better because our PRX declined. Now, after these ventilator changes, the SpO2 here in orange, again, the pleth remains about 94%. So we optimized our PEEP ARDS protocol, at which point we got a durable increase in SpO2. Our pAO2 on blood gas increased to 164. So our P to F ratio, we got it back, right? And with that, there's resolution of the brain tissue hypoxia, not because of the pAO2, but because we were able to saturate the hemoglobin. And that was the key, right? So what happened? You just watched this patient develop pneumonia over time in front of your eyes. It was confirmed by bronchoscopy. And we recognized that the brain tissue oxygen, while initially requiring perfusion to be optimized, suddenly shifted and required us to focus on the lungs instead. not the pAO2, but getting the lungs to saturate hemoglobin to facilitate delivery of oxygen into the brain. And that dynamic is really, really critical, because otherwise we might have continued to push our CPP up even higher, potentially, or pursue other avenues that aren't what this patient needed. So oxygen supply is critical, but in order to sustain neuronal tissue, it has to be used. So bring our attention back to what pbtO2 is recording. I want you to note the left side of the equation, of course, which is oxygen availability and cerebral blood flow. But look at the right side. This is a really important aspect of pbtO2. That's the consumption of oxygen. So how does the consumption of oxygen impact pbtO2? Well, going back to our oxygen dissociation curve, hemoglobin releases more oxygen in response to the metabolic rate of that tissue, particularly in highly aerobic tissues like neurons. But what about anaerobic tissue? And anaerobic metabolism is going to cause an increase in acidosis, right? And an increase in paCO2 with metabolism. Both of these things will offload more hemoglobin. But as cerebral blood flow, shown here in the x-axis, declines, what we see is that as the CBF declines, our oxygen extraction fraction has to increase until such point as the metabolic rate actually decreases, falls, and that's ischemia. And for ischemia, this makes sense, but not all secondary brain injury is ischemia, right? What if you just lower the pbtO2? What if you just create hypoxia in the oxygen supply, whether that's due to barriers to diffusion, abnormal capillary filling? In either case, decreasing oxygen, now on the x-axis, is pbtO2 in reverse, lower oxygen this direction. As that falls, our AVDO2, while initially increasing, falls as well, meaning you're not pulling off as much oxygen, despite the fact that there's lower systemic oxygen. And while you generally preserve your OEF, it tends to be a little bit lower. So the nature of the hypoxia versus the ischemia, the change in how much your tissue can actually take up and use oxygen, is to some degree different, hinting at some metabolic contributions to low brain tissue oxygen, mitochondrial dysfunction, for instance, or increases in demand. So whether hypoxic or ischemic, these secondary brain injuries do create metabolic vulnerability. It's reflected by the brain tissue oxygen. Either it's a primary function of cerebral blood flow or the differences in arterial to venous partial pressure of oxygen through the capillary bed. Some secondary brain injuries substantially increase CMR2, and that may outstrip either of those problems. So seizures, for instance, can occur in about a quarter of patients after traumatic brain injury. And when these frequent epileptiform discharges during seizures occur, the pbtO2 declines, both with the onset and with the speed of those epileptiform discharges as they become faster in a dose-dependent fashion, suggesting that there's increased CMR2, ramping up the oxygen extraction fraction, limiting the amount of freely diffused oxygen in the interstitial space. Spreading depolarizations of brain tissue occur in 55 to 60% of TBI patients. And in a region neurocontusion, these mass waves of depolarization can be recorded, and they induce a massive increase in cerebral blood flow. And as you can see here, the pbtO2 increases as each of these depolarizations occurs. There's a hyperoxic response. But as this secondary brain injury evolves, the mechanisms become inverted. And the high metabolic demand of repolarizing all that neuronal tissue creates a drain on the pbtO2. And there develops an inverse hemodynamic response as well. So you end up developing hypoxia as a result of this increased metabolic demand. I'll show you an example of what I mean in a patient also undergoing microdialysis measurements as part of our multimodality neuromonitoring. This is a patient who also had a left subdural hematoma that was evacuated. You can see we have a monitor on the right as well as a strip electrocorticography on the left. And those are recorded here. Now it's post-trauma day 3. We've got 8 hours of our multimodality monitoring here. And what I'll show you is that in this red box are increasing periodic discharges arising from the areas being recorded. And at the same time, you can see that the lactate to pyruvate ratio, an indicator of metabolism, abnormal metabolism within the brain, increases along with glutamate, a marker of hyperexcitability. Now, the brain tissue oxygen in this context is borderline. Now, you might argue it sort of tracks with the CPP, but the hypoxia also occurs here during the second half of this red box, even though the CPP is maintained a little bit above where it started. And our SATs generally are 98 to 100% here. So our oxygen is reflecting this increased consumption. You can see the EEG here, all of these spikes at 1 to 2 per second, kind of showing you how active this and irritable this tissue is. So midazolam, benzodiazepine, was given to abort these epileptiform discharges, effectively reducing the CMRO2. And once you can see the effects, once you do that, you see the effects on the lactate pyruvate ratio and an increase in diffused substrate, glucose, and pbtO2. But it was short-lived. All this stuff began to decline again, including the pbtO2 and the glucose. Our markers of metabolism worsened, and our markers of hyperexcitability as well. So a midazolam drip was started. And with that, even though our CPP is still on the lower end, our pbtO2 increases along with our glucose with improvements in the lactate pyruvate ratio. So we were able to mitigate the effects of this increased metabolic demand, the mismatch creating a problem of not supply, but of demand in this equation of secondary brain injury. So if it all makes sense so far, you might expect that if we use brain tissue oxygen as part of clinical care and multimodality neuromonitoring, it should help our patients, right? And what's the evidence for that? Well, there have been a number of studies looking at multimodality monitoring, sort of writ large. 43, in fact, use more than one modality in patients with traumatic brain injury specifically. You can see down here, this is the studies incorporating pbtO2. And in this Circos plot, you can see how they are described in relation to microdialysis, or how ICP is described in relation to pbtO2. Each of these bands describing the number of studies based on the thickness of the band and their relationship with the other variables studied, things like EEG, TCDs, or regional cerebral blood flow. Now, what I'll say is that 2/3 of these are observational. Half actually came from the same research group. All but 2 of them use ICP monitoring, and 4 include just ICP and non-invasive optical imaging. So, when it comes to these studies, they're very heterogeneous. But what I'll point out is when you talk about interventional studies where the multimodality neuromonitoring guides care, clinical outcome seems to result from the interplay of our multimodality neuromonitoring and the interventions. And 9 of these studies, which include outcome as an endpoint, 7 of those, or 80%, showed improved outcome in favor of the multimodality monitoring guided therapy. 5 studied intracranial pressure and pbtO2 after TBI specifically, one of which was 113 patients admitted with TBI. And what they did was they started a service line with neurocritical care consultation and the use of intracranial pressure and brain tissue oxygen, in addition to markers of autoregulation. And what they found was it changed management. The arterial blood pressure was higher on average. There was better temperature control. And this platform of care, including multimodality neuromonitoring, focused on pbtO2 in addition to ICP, was associated with 2.5 increase, or an increase in odds for better outcome of 2.5. So this is good evidence that doing this may actually help. And you can actually do this in a fashion that's targeted specifically at the physiology, not just instituting neurocritical care consult, but really focusing in on the ICP and pbtO2 guided management. The Boost 2 study is one that showed us that you can intervene and improve pbtO2. And in this case, although underpowered, 11% more patients had favorable outcomes in the group that relied on pbtO2 management, in contrast to those who were treated for just their intracranial pressure. In a meta-analysis, including 15 different studies, more than 2,000 patients, including that Boost 2 study, for instance, the pooled odds ratio for 6-month outcome favored the use of both ICP and pbtO2 therapy together. Now, notice these aren't encompassing cerebral blood flow, microdialysis, and all the other stuff that we just saw, but even rolling in intracranial pressure, giving you that context of the mechanics and the metabolism and how those overlap with brain tissue oxygen seems to favor its use to improve outcome in that case. But there's an increasing number of studies that are using sophisticated trial design, not just observational studies, emerging to try to provide some definitive evidence that managing severe TBI patients this way helps. The first one to be published at this point is the OxyTC study, a French study that compared ICP and pbtO2 management to ICP management alone in in almost 300 patients. What you'll notice is these are sick patients. A quarter of them had non-reactive pupils bilaterally. A few of the subdurals were actually evacuated. But a third of patients where they measured pbtO2, and that was the group with ICP and pbtO2 targeted therapy, had critical brain tissue hypoxia. We don't know what the group that was only ICP actually had, unfortunately. And three-quarters of folks received brain tissue oxygen targeted treatment. So many, many more people got treated relative to who had critical brain hypoxia. And what they found was overall the odds for outcome improvement or worsening were no different. Now, what we can point out is one, they used hourly measurements of intracranial pressure and pbtO2, which increasingly we recognize the burden of ICP or dose of ICP is important. There was no blinded pbtO2 comparison. And I want you to notice in their intervention list, the first thing is to address the PaO2, which, as we said, is not the usable oxygen that our brain worries about. Two additional studies are coming down the pike, which I think are really going to be useful because they do vary in their study design. In the North American Boost 3 study, we're comparing early intracranial pressure pbtO2 monitoring. Everyone gets both monitors. One group is blinded within 12 hours of injury with nearly 1,000 patients planned. And then the Bonanza study through the New Zealand-Australia group, ANZIX, which is international. It's sites all over Europe and Australasia, is going to be kind of a sophisticated sort of multi-phase study. And in one of those phases, phase 2, patients will get both pbtO2 and ICP, all within 24 hours of injury. So there are differences in how quickly you get these therapies based on how quickly you get the monitoring. And we'll have to see what shakes out in the end. But hopefully I've convinced you, if you have a good kind of idea of the physiology that you're dealing with, there's some practicality to using this to infer the things that your patient might benefit from outside necessarily of a clinical trial, based on a lot of our observational evidence with experienced folks using this. And so some practicalities of using this now, once you have a handle on these physiologic underpinnings, you know what it's measuring, you can do this in a couple of ways. The first place to start is just organizing any of the measurements you're using, ICP and pbtO2 to start maybe, just to recognize what's normal and what's outside of normal. These values aren't set in stone. A patient may be doing fine with a pbtO2 it's 25, or they may be doing poorly with a pbtO2 of 30. But in terms of normals, what you want to know is whether there's brain tissue hypoxia based on established norms from the literature. And the situational awareness this creates, that's important, right? Simply identifying brain tissue hypoxia then allows you to say why. And while you're asking why, the other important step is to identify potential therapeutic options based on what you know. And there's consensus statements now that make use of these two common monitoring modalities, ICP and pbtO2, that allow you to say, well, which box are you in? Is your ICP abnormal? Is your pbtO2 abnormal? Here are some things that you might consider starting with based on all those physiologic principles we just talked about, right? So maybe you have to focus on ICP because your CPP is already as good as it's going to be. Pushing the CBF may not help. The CMRO2 is already low. You're sedated, right? So let's focus on cerebral edema. And there's options here to do that versus the patient where your CPP is too low and your ICP is elevated, but we have to get the perfusion pressure up so that we auto-regulate better. These protocols aren't perfect solutions, but they give a structure to the methods that you can use, like a menu of options, right? Recognizing that things are complex. And what's interesting to those of us in the room who like this kind of physiology, that complexity can really nicely inform the heuristics that you might use to treat patients in an individualized way. So as you dive into these other measurements, you get to think out what's going on at the histopathologic level, right? In some respects, in real time, in a very refined and precise way. Thinking through these classes of hypoxia, for instance, You can see how perfusion of oxygenated hemoglobin, for instance, versus diffusion hypoxia and other barriers to oxygen diffusion, or hypermetabolism, mitochondrial dysfunction, right? These mirror those causes of hypoxia we just talked about that we can intuit by using pbtO2 in context. So in the end, pbtO2, I hope I've convinced you, is a complex number. It really blends mechanics and metabolism and even function of the brain to identify tissue hypoxia in its numerous causes, right? It can occur from a lack of oxygen delivery, impaired diffusion of oxygen, or increases in metabolic demand. But if you use multimodality neuromonitoring, use your other data, you can individualize management to address the problem in that given patient. And our evidence is increasingly suggesting that the thoughtful use of brain tissue oxygen monitoring in this kind of context may improve the care and outcome of patients with TBI. So with that, I'll say thank you, stop, and hopefully we have some time for questions.
Thank you, Dr. Foreman. We do have a question in the chat right now. Just a reminder, everyone, the Q&A button at the top of the menu bar, you can enter any questions there. So we do have a question. Do microhemorrhages near or around the probe affect the pbtO2 readings? And if so, how is this troubleshooted?
Step in trying to understand whether the probe is being restricted from measuring diffused oxygen, which could be from microhemorrhage, from microtrauma and edema that forms around the probe, is to do a PaO2 or FiO2 challenge. So if you increase the FiO2, you know that your PaO2 is increased, leading to an increase in the diffused oxygen within the interstitial space. If your brain tissue oxygen doesn't increase, there's no response, then you can infer one of two things. One is there's no blood flow to the area and no diffusion of oxygen. Or more likely, if a probe has been placed very recently, within an hour or two, that very likely there's some microtrauma there that's preventing oxygen from diffusing into the catheter. Typically, what's done in that situation is you wait because it goes away. And in one of our initial looks at using the RAUMEDIC catheter in particular, we found that there was a median of about 8 hours between placement and between a clearly reactive probe. The BOOST study uses 5 hours as a window where we assume that there may be a little microtrauma. And increasingly, for whatever reason, our placements now in our multimodality neuromonitoring patients, we actually get a pretty reactive pbtO2 right off the bat. So it is variable, but having that test in mind, it's reactive. Even though that pbtO2 is low, you can be pretty sure that there's not microtrauma that's impeding that oxygen diffusion. And that's the biggest issue I run into, is people see a low oxygen, they say, it's probably an artifact, it's probably nothing, there's probably microtrauma. But the FiO2 challenge, it's clearly a reactive tissue oxygen response. You got to take those at face value as true brain hypoxia.
Excellent. Thank you. Thank you. I had a question for you, Doctor. So just kind of with pbtO2 monitoring becoming more common, and I know Cincinnati has done this for many years, but any advice for kind of new hospitals or doctors that may be considering it, but may be concerned just, about monitoring kind of another parameter and all the challenges with that?
Yeah, in terms of, practicalities of placement and complications, you mean?
Sure.
Yeah. So what's encouraging, I think, is that the overall rate of complications is half or less even than the complications of placing a external ventricular drainage catheter. So in many cases, where someone is already, appropriate for an intracranial pressure monitor, say, using brain tissue oxygen either from the same catheter or from the same burr hole approach is something that's relatively safe. And those numbers range from 1% to 4% for what's called a significant hemorrhage, for instance, one that requires medications or surgery. And those numbers range, of course, but certainly less than what's reported in the EVD literature on average. So it's relatively safe. The microhemorrhage and microtrauma that occurs during placement, in general, those are non-significant. There's not a tremendous amount of injury that's left over, say, on an MRI in delayed fashion. And generally, it's just the result of the probe placement, and that resolves fairly quickly. And so I think, in general, we think of this as being relatively safe for the return on investment that you get of placing these in terms of patient care, which can change dramatically.
Very good. Thank you for that. I saw another question come across in the chat. Where should the tip of the electrode be? In the white matter, but if it is in the caudate nucleus, for example, does it make a difference?
It can. There have been studies that do show that there are differences in pbtO2 within white matter versus cortical gray matter or potentially subcortical gray matter. We know there's differences in blood flow in those regions as a component, of course, of what it's measuring. In general, the placement's recommended to be some, 2.5 or so centimeters under the skull, which typically puts you within subcortical white matter. But what I will say is that the lower end of the threshold, if you're looking at a pbtO2 of less than 20, less than 15, whether it's white or gray, that's too low in general for brain tissue. And so you can still use it in a similar fashion, even though maybe the norms, differ by, 20 to 30 millimeters of mercury versus 25 to 35 millimeters of mercury. The lower end is still what you can reliably treat to.
Very good. Seeing another question come across in the section, are the pbtO2 monitors MRI safe? I might be able to go ahead and answer this one, Dr. Foreman.
I was going to say, I'll defer to you on that one.
Sure. So in many countries, we do have full approval already. Speaking for the US, we recently did receive conditional approval for the MRI catheters. Now, there is still some work we have to do on the back end with some manufacturing, IFUs, and just some background stuff like that. So we're expecting, hopefully early next year, the MRI conditional ones will be able to ship out. Now, also, that may depend on the type of bolt that you are using. I know, Dr. Foreman, at Cincinnati, you guys use kind of a multi-lumen bolt that is steel. And so we do have a single lumen bolt for our probe as well, which was also, MRI conditional, which is made out of PEEK plastic. So it might determine the type of bolt you are using as well as kind of the probe to get that measurement, if that makes sense. Okay. Let me check. Okay, we have another question. How far should the tip be from the hypodense ischemic area that we see in the CT scan?
So you want to spark a debate, do you? It's a good question. I think in general, the recommendation at this point tends to be placement of the probe within relatively structural normal tissue. However, pbtO2 measurements that are closer to a contusion, and that depends on who you ask in terms of what that might be, but within 2 centimeters or so in a peri-injury penumbra may have more prognostic implications. So those values may portend prognosis more accurately than pbtO2 that's measured in structurally normal tissue. I think from a management standpoint, I often want to know sort of more globally what's happening with autoregulation, with perfusion. And so having that in the relatively normal tissue is a bit more helpful for me. But that said, if it's in a penumbral area, that data is actually quite useful, just in a very different way. You're really targeting more of a focal pathology there, optimizing that peripenumbral or that peri-injury area. And so, the practicality is that it's often difficult to target location if you're placing these at bedside with a burr hole. You have, generally speaking, 2 options, right? In the subcortical frontal white matter on the right or the left. And often your hands are tied. If you've done a decompression, you've only got one side you can point to. And in our case, we for many years tried to, I think, target peri-injury tissue, but found that for those practical reasons, about 75% of our folks ended up being monitored in structurally normal tissue. But I think that's become sort of the standard for this form of monitoring. And hopefully that helps.
Very good. Well, that is all I am seeing for questions right now from the chat. Thank you very much, everyone, for your attendance. Thank you again, Dr. Foreman. That was a fascinating talk, and we hope to do more of these in the future. But again, just a reminder, everyone, you will be getting a recording of this webinar to review again, to share with your colleagues. But again, thank you for everyone's time, and until next time, we'll see you again. Thank you very much.
Thank you all. Very much appreciated. Take care, everyone.